Welcome to the DaVinci Hour, a podcast series that interviews individuals across the field of medicine to help provide an inside look into their experiences and provide insight on how to navigate the journey of becoming a physician. My name is Dr. Maxwell Cooper, and I will be your host. This podcast is brought to you by DaVinci Academy, a medical education company that provides online video courses, outline format books, and clinical case videos for students studying the medical basic sciences. You can check out all that DaVinci Academy has to offer at www.dviacademy.com.
All right, everybody, welcome back to the DaVinci Hour podcast. I am joined by Dr. Cullen Ruff here today. He is a radiologist and then also a author as well. Dr. Ruff, thanks for joining us.
Thanks for having me, Maxwell. Glad to be here.
Great. So a little background, Dr. Ruff is an attending radiologist in private practice at Fairfax Radiology Centers in Fairfax, Virginia. He's also an associate professor of medical education at University of Virginia School of Medicine. And then he began his education at Duke University, where he got his bachelor's and then his MD at University of North Carolina School of Medicine. So I guess he's a Blue Devil and a Tar Heel. And then he completed his internship in internal medicine at New Hanover Regional Medical Center in North Carolina, and then went out to University of Colorado for his radiology residency, where he was also a chief resident, and then completed his training with a fellowship in abdominal imaging at Georgetown University in Washington, D.C. And then he is also the author of a new book titled Looking Within, Understanding Ourselves Through Human Imaging. So here's his book right here. And we'll get more into that. And it's just a brief statement on that. It provides nonfiction narratives about new discoveries in patients through medical imaging and how those provide a unique window into their lives. So Cullen, again, happy to have you on here. Maybe we could start out with you just telling us a little bit about your current clinical position, kind of, what types of imaging you specialize in. You mentioned you do some procedures and kind of how you break up your clinical time.
Sure. Well, I am lucky enough to have been with the same practice since I got out of fellowship, which is not always the case, but I have been with my company, Fairfax Radiology Centers, for over 22 years now. And because I did an abdominal imaging fellowship, I do a lot of standard CT, ultrasound, MRI, and that includes a lot of cross-sectional interventional procedures. So a lot of biopsies and drainages. The type of work has evolved over the years. This practice has grown substantially, and it has gotten a lot more subspecialized with the size and the depth and the breadth of knowledge and expertise that we have. So we still read plain x-rays and all of that, but I feel very fortunate to be in the group that I'm in. Very cool.
And then I guess what are kind of the bread and butter procedures you do? You mentioned you said you do some mainly like is it abdominal biopsies, and then you said percutaneous drainage placement as well, it sounds like.
Absolutely. So we do a lot of biopsies all over the body, really. And then, of course, drainage procedures, chest tubes, abscesses, gallbladders, whatever needs. I happen to do a lot of prostate work as well. So we read the prostate MR, and then I do the fusion biopsies using the MRI images with ultrasound fusion in order to biopsy suspicious lesions.
Oh, very cool. And then outside of your clinical work, it sounds like you've done teaching now for a number of years now with medical students, it seems.
That's right. So our hospital, Inova Fairfax, which is one of the largest hospitals in the state and in the DC metro area, became a satellite campus initially for Virginia Commonwealth University out of Richmond. And that was way back in 2005, as I recall. And so I was one of the preceptors for the medical students who were doing elective rotations at our hospital. And just this past year, we transitioned from VCU to University of Virginia out of Charlottesville. So it's the same work essentially, but in a different affiliation.
Gotcha. Now, do you do more kind of lecturing the first and second year medical students, or is it them rotating through clinically as third and fourth years, or maybe a mix of both of those types of teaching?
No, it's third and fourth years. So
okay.
I believe all of the first and second years are still in their core classrooms in Charlottesville. And then a proportion of the class comes up to do their clinical years at our hospital here in Fairfax. So we have third years rotating through who are getting just a taste early on if they're interested in possibly pursuing radiology. And then we have fourth years who are doing a full month elective.
Gotcha. Okay. And then I guess, given that, are you also teaching residents, or is it mainly you're teaching focusing on medical students right now?
We don't have radiology residents in our
Okay.
hospital. So there are a lot of residents in fields like surgery, medicine, family practice, ER, OB, pediatrics. So a lot of these fields that we're teaching indirectly through conferences and daily case review, but it is primarily to the medical students for radiology, which I look at as a blessing because I know that I've probably got a little more knowledge base than medical students. By the time some of these smart residents get there, I'm not sure that I've got a whole lot more to add. So I say that I hope in jest, but anyway, yeah, it's students who are coming through our department.
Very cool. I'm curious, it sounds like you've been involved in medical student education for a long time. I think radiology is one of those specialties that maybe med students don't get adequate enough exposure to. I guess, what have you found as kind of effective ways to get them, I guess, more involved during the rotation, or more interested in the field, or more likely to consider it?
Everything you said is true. A lot of what students get exposed to with radiology is not from radiologists. And they pick up certain patterns of interpretation or ordering from non-radiologist clinical doctors, many of whom are quite knowledgeable and familiar with what to order and when, but I'd prefer that they get it directly from the source. So I do give lectures. As soon as they come in, we start off with the chest x-ray lecture, and then I've got other lectures that I try to interject whenever the school can get the students together and give me block time. Mm-hmm. And then, of course, when the students rotate through the service, I believe one of the most important things that a student needs to get out of a month's radiology elective is a better understanding of what each modality can do and when is the best time to order a CT or an ultrasound or an MRI on which type of patient, on what age, of what condition. So a lot of it is patient driven, depending on the patient's condition. One of the goals I have for the students is that they get a better understanding of what to order.
Gotcha. Yeah, no, I think that's important. Even if they don't go into radiology, that's, I'm slowly learning the struggle of reading images where you're not exactly so sure they were indicated or not.
That does not go away, trust me. But we try, and we try even with people who have been out in practice for a long time, who may have certain ordering habits that might need a little tweaking. And I learn on the job every day too. So when we work together, I think it's in everyone's best interest.
Sure, of course. And then I guess as far as the diagnostic imaging side of things, you did your fellowship in abdominal. Do you focus mainly on the abdomen, or I know a lot of radiologists in private practice also kind of can read all over the body, and then sometimes they do focus in one area. Where do you kind of fall on that spectrum?
My area, as well as everyone else in my section, tends to be chest, abdomen, and pelvis. Okay. So we have enough specialized musculoskeletal docs who are doing the joints and the neuro docs who are doing the brains and spines. So it does tend to be chest, abdomen, and pelvis work.
We're going to take a quick break to let you know the DaVinci Hour podcast is brought to you by DaVinci Academy, which provides online video courses for the medical basic sciences. These courses are taught using a variety of teaching methods, including bullet point outlines, diagrams, radiology images, and chalk talks to explain the fundamental concepts. We then teach the application of those concepts to numerous clinical pearls that are frequently tested on medical school exams and the USMLE. Our video courses are available on our website, dviacademy.com, as monthly subscriptions starting at $9.99 per month. Each video course has a corresponding outline format textbook as well. You can find the link to our website in the description below. Also, be sure to use the discount code TDH20 to receive 20% off any of our video courses. All right, now back to the podcast.
So I'm curious, going back to medical school, since we're speaking of med students, what made you go into radiology? And I think you talk a little bit about this in your book, but I'm curious to hear from yourself what how you arrived at that decision.
Well, I don't talk about this specific aspect in the book, but I think I was one of the late bloomers in terms of making a decision.
Mm-hmm.
In fact, to the point where I intentionally delayed graduation so that I would have more time to do more electives. It was serving two purposes, because I finished the first 3 years on time. And then the deans, of course, said, okay, everybody, it's time to start applying. And I truly did not know what field I wanted to go into. And I talked to the deans and I said, look, I want more elective time. There's no rush here. And what I also wanted, and I'm not advocating this for every student, because I'm sure that every dean out there would love to wring my neck if they heard this. It's not advice. I'll just tell you what I did. I took a semester off and I went to go travel.
Oh, wow.
Because I was having a lot of fantasies about being able to, before I got too old and too set in my ways as someone older and more rigid, I wanted to do the fancy free youth hostel type overseas traveling. And I knew that once you start internship and residency, it's really hard to do that. So it worked out well for me to just take a semester off, go sow some wild oats and see some sights, and then come back and have 6 more months of fourth year starting before I had to apply. And it was during that period of time where I took a radiology elective, just because most people do, because it's so integral to most fields of medicine. Really, if you don't, other than psychiatry, which may have a little bit of brain imaging, and dermatology, which does not need much internal imaging, besides those two specialties, just about everyone else orders a lot of imaging and relies on it. And it was that elective that opened my eyes and told me, you know what, this is actually really cool. And the thing I like about radiology, one of many things, is that even though you can't do all of the surgeries that different specialists do, all of the procedures, and know the ins and outs, you keep up a little bit with what a lot of different people do. So you have to learn a little bit about what the bariatric surgeons are doing, or the urologists, or the endocrinologists, or whoever. And it allows you to just keep abreast of what's going on in different fields. And it was around that time that I decided this would be my path.
Awesome. Very cool. No, that's interesting. I'm curious, where did you travel about?
I went to Europe.
Okay.
Yeah,
Nice.
I went to several countries and had a great time. I'm glad I did it.
That's awesome. Now, were you a non-traditional student, or did you go right out of undergrad to medical school?
I worked 1 year in a lab doing research,
Okay.
and then I started med school. So just that 1 year.
Okay.
And then, because I was a December graduate from med school, I did 6 months of mammo research before I started internship.
Oh, nice. Okay.
Because I had that semester to kill and do something with.
Yeah, a couple of things you said are interesting. I agree with you. I think so many medical schools don't give you, and I don't think it's maybe not necessarily a fault of their own, but you just don't get enough time, I feel like, a lot of times, to figure out what you want to do. And it's a big decision. So I guess I applaud you for, I think a lot of people talk about doing that, but few do it. And obviously there's personal constraints with taking extra time like you did. But yeah, I think, it's a big decision, and taking that time, you definitely got to think through it for sure. And then I think on the flip side,
it was one of the smartest things I ever did. It took some guts,
yeah,
and a little bit of convincing. And it was interesting because I remember some of my classmates, when I went ahead with this formally, I remember some friends of mine in class saying, "Oh, I wish I could do that." I said, "Well, the dean's office is right down the hall." But I'm not actively advocating that many students do this. But for those who truly need more time before you get into the groove of internship and residency, and particularly if you need time to figure it out, I think there are better exposure opportunities for third years now. We have them at our hospital campus, where third years interested in a certain field can at least do a 2-week exposure type thing. It's not much, but it at least allows you to glimpse it.
Sure. And as just recently completing intern year and then doing radiology residency, I can certainly echo that you don't have time to do those certain types of activities, like traveling and exploring new opportunities and things like that. So, and I think what also completing intern year, what I think is interesting that you said also, is that I think having that perspective has certainly, I see why we have to do that. As much as I got frustrated on the ward sometimes last year, I can see where that experience definitely holds a lot of value. I really couldn't imagine starting residency right out of med school, or at least radiology residency right out of med school, without that like foundation in clinical practice.
I agree 100%. And I've listened to a few of your other guests on your other podcast episodes, and others have echoed what I agree with, which is you really do learn an incredible amount in your intern year, even though some of it may not be the type of work that you carry forward using on a daily basis long term. Like someone mentioned the sliding scales for insulin dosing and all of that, but you get a lot of fund of knowledge that comes in handy.
Definitely. I'm curious, do you think, one is more valuable than the other, or maybe it kind of suits a personal interest, maybe, doing like a surgical year versus a medicine year, or like a transitional year like I did, because I was able to do some medicine and some surgery. Do you think it's kind of just maybe what you want out of it, or do you think there's maybe certain advantages to one path?
I imagine that either is fine. And the only thing I tell students who are going in is, if you get elective time as an intern, don't do it in radiology. Mm-hmm. You're going to get all the radiology training you need. If you have elective time, do something that you may not get to learn about again. I think one that is perhaps undervalued and not thought about all the time is doing a little pathology exposure, mm-hmm. because so much of radiology is anatomy and pathology. And it doesn't mean that we necessarily want to be doing autopsies all the time, but you do actually learn a lot of relevant information. So I think whether you choose surgical internal medicine or transitional year, I think any of those routes are probably fine, and there's a lot of overlap. But just try to figure out what suits your needs.
Sure. So I want to get into your book that you've written, and I want to first ask you, I guess, what inspired you to write this book?
I can answer that. I didn't get to do a whole lot of pleasure reading as a resident. Mm-hmm. And literally the first book that I had picked up in a while was when I was on the plane going to take my radiology boards.
Oh, okay.
Which used to always be in Louisville, Kentucky every year. And I made up my mind that once I got on that plane, I wasn't studying anymore. I was just going to chill. And most important thing before a big test is get a good night's sleep. So I started reading a book that I knew would take my mind off of this board exam. And it was just a collection of Sherlock Holmes stories. And I really got into it and thought, this is kind of fun. And then I started reading more. Fellowship is plenty of work, but you're not preparing, at least in my day, you weren't preparing for a board exam anymore. You had already passed it. And so I had a little more time to read. And then I just started getting into literature a little bit more. And that includes reading some other books by other doctors, including a couple of whom I knew or had met. And I was impressed with them. I thought every doctor's book that I had read, and it did not matter what the specialty, and there were some famous ones, neurologists, surgeons, ER docs, internal medicine, infectious disease. I read some really good ones, but I never saw anything by a radiologist. And I remember telling people that I thought I could come up with a book that would show people what I thought was this wonderful, almost magical side of our specialty, because of the unique aspect of being able to look inside of someone's body and to learn about that person as an individual and what has been a disease process or something that's affected them already and therefore has an impact on what their potential future may be. Mm-hmm, mm-hmm. So I got the idea with that and just started tinkering around with some individual chapters, which are basically short stories, but they're nonfiction, and just continued experimenting until I had enough come together where I knew I had hit critical mass, and I was going to continue until I saw it to completion.
Gotcha. So this is something you've really been I guess, developing or composing over a number of years. This wasn't something you kind of wrote in a weekend.
Too many years. I'm going to
Yeah.
be perfectly honest. I started this a long time ago. And again, it started as just an idea, but I knew it was not time sensitive material.
Mm-hmm.
It's the kind of thing that you just build on whenever you get the time and whenever you see an interesting case, a case that really makes an impression on you and you think, wow, this is worth writing down and this is worth sharing with other people, maintaining the patient's confidentiality or anonymity, but sharing the message.
Sure, of course. Yeah, and I guess the cases, it seems like I haven't finished your book, but I've read through some of it already. It seems like you liked picking cases where the patients themselves were interesting people, and then that, such as your intern year that you talk about, and then your later years in radiology where you found something that maybe you weren't necessarily expecting to find, or the clinician that ordered it wasn't necessarily expecting to find, and then how that kind of one gave you kind of a unique perspective into that person's world and who they were, and then also how that kind of impacted their life going forward. Is that kind of the criteria you used, or was there something more to it than that?
That was a lot of it. The way you described it was good. In fact, if you ever want a part-time gig as an editor, I'll put you to work on a future project. That was part of it. Again, it was the process of writing this book. It was organic and it was gradual. Mm-hmm. But whenever I just stuck to what was in front of me, which was real cases that were poignant and illustrative and really taught me something, and I thought it was an intriguing story worth sharing, then it all just eventually kind of fit together.
Gotcha. One thing I'm thinking of is as we're talking about cases, because I write some educational cases material, but I think for this book, you mentioned patient confidentiality. How, when you write a book like this, do you have to get patients' permission, or is it a matter of just kind of changing the details enough that that's kosher? I guess how does that, I'm curious how that goes about.
It's more the latter. So as long as you do not put identifiers, it's one thing it's okay if the patient reads a story and says, well, that sounds like me, but as long as no one else can read it, who's unknown to them, and say, hey, I think that's John Smith on the next block or whatever, well, then I think then legally that should work. Gotcha. In terms of protecting people's privacy. You're not saying who the person is. I don't usually use real names, or certainly not last names, but I usually would change the first name if I gave them a name. And then you don't necessarily describe what city they live in, because some of these, again, are from different parts of my career in different places. So as long as you're being general enough, I think that's fine.
Okay, that makes sense. Versus if you read a CT scan for a movie star and you said such and such was in Hollywood and starred in this movie,
can't do that.
You can't do that. Yeah.
or in my town in DC, you can't mention that the person's in Congress or anything else, because we see that's our local celebrity, and no, you can't do that.
Gotcha. That makes sense. Okay. So maybe I'm curious a little bit more about the kind of the writing process. Was it like you would see this case and it would go off in your head, like when you're in the reading room, like, oh, I should, keep track of this? Or was it more like kind of just reflecting over time? Or I guess maybe kind of go through that process, how you want, because I imagine you had more cases that you could have used than you actually used in the book. It was probably, maybe that was a process even its own, kind of narrowing it down.
I mean, think about it. Yeah, and as an attending radiologist, you read you read in the low 5 figures every year. So easily over 10,000 cases a year. I haven't even done the math. It's probably more than that. And with each one of those are many images, if it's on, a multi-image study like a CT or an MR or whatever. So it's usually the case that just gives you the wow factor, and it either haunts you or it stays with you. And a lot of these in the book are the first time I ever saw X. So, for example, one of them that you may not have gotten to yet is probably at least midway through, and that is the first time I ever saw unsuspected child abuse. Mm-hmm. And I'm not a pediatric radiologist. I was just at the outpatient office the first year in practice. It was cold and flu season, very busy. A lot of people coming in with coughs, getting chest x-rays. And that included a 4-month-old who had a cough, and the mother brought her in, and the x-ray showed no pneumonia. But as I was pulling it down, because it was film back then, not digital, I suddenly saw, wait a minute, there's more to this story. And I saw healing rib fractures that were not something that a 4-month-old would be able to have inflicted by their own limited ability to injure themselves by not being able to move around very much yet. So I knew there was more going on. And that led to the drama of notifying the pediatrician, then getting the full skeletal survey, then having the parents react and question what's going on, and having to explain what we are finding to people who are obviously concerned, but might even be possible perpetrators here. And that's not my role to figure out who was causing the abuse, but it's an inevitable consideration. And so I talk about those sorts of things in that story. And these are all very short. They're very easy to read. I geared this book toward non-medical general audiences, but that's the kind of story that sticks with you. And it might be, there are stories that are the first time I ever found certain cancers, or saw horrible spinal injuries, or the first time I diagnosed infertility and had to explain to someone, it looks like you're not going to be able to get pregnant without intervention that you may not be able to afford. These types of stories, they just kind of stick with you. Complications, there's a whole section of those in there where you're doing biopsies or procedures and you're doing it by the book, and yet inevitably things can go awry. And sometimes, despite doing everything technically correct, a bad outcome can happen. And then is there anything you can do to fix it? So these kind of things stick with you.
Yeah, and I can certainly echo that. As I'm obviously very early in my training, but I can remember, cases that I read months ago that, where I found a new cancer or something like that. I still remember it, and remember that it's weird because you're kind of excited as a trainee, like, oh, I actually, found something, or I was able to identify something. But then I think it's something interesting you talk about. And I actually think about this a lot, where you think about the patient on the other end of that. As radiologists, we may not necessarily get to see that, but I always think of that, especially if I get fatigued or it's later in the day and it's like, as like an outpatient study where, there's a lot of different nodules or things like that. I think, this patient is probably very nervous about this exam, is very, they're kind of waiting on pins and needles to see what the radiologist said. The oncologist is waiting. And I think it's, I hope I don't lose that. I hope to keep that thought in mind as I progress, and kind of thinking about the human side of imaging.
Well, it's a very important point that you bring up, because these are all real people. And it's not just oncology patients. Remember, the way I look at it is every day you read CT of the abdomen, you're going to find kidney stones. Mm-hmm. And every evening that you read x-rays out of the ER, you're going to see a fracture. And every night you read ultrasound, you're going to see a miscarriage or two. It just happens. This is normal for us. And yet, that even though these conditions are typically self-limiting, these are not cancer diagnoses, most patients are going to remember when they had their kidney stone or their fracture or their miscarriage. These are important events in people's lives. And if you just remember that even if something is routine to us, it's of vital or at least critical importance to the individual, and it is a real person being scanned. And I think it makes the job more rewarding just to keep that in mind.
Certainly. I guess back to kind of the writing aspect of things, you mentioned you wrote this over a number of years. Did you have a lot of, growing up, were you someone who, did a lot of creative writing, or, did you, in your off clinical time, write a lot of blogs or like news articles, or, even just research papers or things like that? Is that something you've been involved with for a long time, or no?
I would say not really. I had a few publications as a student. And then when I worked in a lab for a year, I got my name on a few papers, but no, it was not it was not a definite passion of mine, creative writing. I did a little bit. I wrote a few short stories in my 20s and enjoyed that and thought perhaps I could put a collection together someday. And that is, I have actually worked a little more on that here and there, but that's still maybe half finished. I don't know. A good thing I'm not relying on that to pay the rent. But I don't know that I was certainly not an English major. I was not someone who read extremely voraciously. It depended on the phase of childhood or young adulthood opportunities. But once I got the idea and felt this passion for it, especially when cases would continue to present themselves and feel like it was part of a thread of this tapestry I wanted to weave. Forgive, that sounds like a cliche, but just kind of trying to share with other people this incredible, the magic that we can see in this beautiful field of ours called medical imaging.
Mm-hmm. Definitely. I guess I'm curious, what was the most challenging aspect of writing this book? And I imagine part of that maybe was, maintaining your full-time job and kind of splitting your time between these two.
Well, getting it done, if somebody in your audience here is interested in writing, I could say a lot on that. You have to be patient with yourself and go at the timetable for the work, first of all. So I put this aside for a number of years repeatedly during the period of time between start to finish. And the publication process is challenging. It's time consuming, part of it just because you have to submit and wait, whether you are trying to get a literary agent and then trying to get a publisher. And all of these things take time and they take persistence. And I think that's the real challenge. There are different ways to publish now. The field has evolved a lot since I started. And so you have to learn the ins and outs of all of that. And nowadays with social media, there's a lot of extra work that good authors or successful authors have to do in order to try to promote themselves, because even if you have a big time publisher, there's only so much promotion and PR that you're going to get. And so you have to be active in different ways to try to get your work out there. So those are some of the most challenging parts, I think.
Gotcha. And I'm curious, as part of promotion for the book, I like you recently gave I think you were telling me a lecture with the Smithsonian Institute. I guess what types of things have you done to help, that you have felt have been helpful to kind of get the book out there? Because writing the book's hard enough as it is, but then also you need to get people to know about it so that they can read it.
Very much so. Well, I don't know that I'm the best person to ask, because unfortunately my book launched 3 weeks before this minor little thing that affected us all called the shutdown with COVID-19. So it came out actually right around the time of the shutdown last year. Wow. And so I was lucky enough to have my initial launch party, which was a big event and had over 100 people come to that. And then I had one independent bookstore presentation where I live, and then everything closed down and screeched to a grinding halt. So the live events that were planned have still been on hold. And so that's one thing that people can do, is if you have material that you can lecture about, whether or not it has images, as in the case of mine, I like to joke, my book at least has pictures. But I had some live events scheduled that are on hold. And so then I did have a couple online events with my publisher, which is a small publisher, but then you look for other opportunities. I've been invited on a few other podcasts like your own, and then I did get referred to the Smithsonian. It was actually just an acquaintance of mine who came to the one bookstore event I got to give in March of last year, right before the shutdown, who liked the presentation and said, "Hey, I know somebody who has lectured with the Smithsonian. He's a historian. Your fields are different, but you should meet him, and perhaps he can refer you." And so I waited at least 6 months because I thought, I don't know, why would they want me? And then finally I just thought, well, what have I got to lose? And so the people at the Smithsonian were wonderful. And I had to pitch and give a written presentation and be interviewed. And then they said, this is something we've never done before. And an event on human imaging, but we think our audience would be very interested in this. And so I just gave that last month, and it was well attended and it was very well received. And I was really happy about that. It was a smart audience. They asked good questions. So those are just the types of things you have to do. I do think, however, when live events are more numerous and prevalent, I think it'll be a little easier.
Gotcha. Yeah, and congratulations on that lecture. That's a huge honor to present at the Smithsonian, and I'm happy to hear that it was well received. Is that something you gave like virtually through their website, or I guess I'm just curious how they had you do that lecture?
It was a virtual event, yes.
Okay, gotcha. Yeah, and then I imagine the live events, were they I guess kind of traveling throughout the country that you had planned to, at different like bookstores and other events like such? Is that kind of what you had planned out to help promote the book?
I was going to just start regionally and then take it as opportunities arose. But yes, that's the way it works.
Gotcha. Okay. I guess, and you touched a little bit on this, what advice do you have for, I guess, physicians at any stage, whether they're a resident, fellowship, attending, or even maybe a medical student that are, they have this interest in writing, or like yourself, maybe they see something that's kind of an unmet area in published books that they want to, feel like is an important story to tell. I guess, what's your advice for at least starting out in that realm?
The first thing I would say is you don't have to start with an entire book. So you can test the waters by doing a guest column in a trade journal or a blog, or not even your own blog, but as a guest writer on someone else's blog. People who have, as you very well know, people who have podcasts and blogs are always looking for new material if it fits their goal, their mission. And so just find an audience where what you have to say may be what somebody's looking for, and test it out. See how you like writing, see how you like getting your work out there. Be prepared and get some tough skin, because not everybody will rave about what you say. You'll usually if somebody's taking your work, it's going to be received well and reviewed well. But there's always going to be the outliers and the exceptions, and you can't take that personally. Although look at what people have to say, and maybe that can be constructive criticism or an opportunity for improvement. And then if people feel that this really is a goal, a passion, first of all, you just got to write. Just do it because you like it. I learned a long time ago that the word amateur does not mean half, talented or whatever else. Amateur just means, it's based on the word aimer, the French word to love. It just means that you do something because you love it, not because you're getting paid for it. And so do something like writing just because you want to. Don't expect to make money from it, because most people who write don't make money, but you can still get your work out there. You can still share it, even if the amount of time that you put into it and all of the effort that you go to is not necessarily financially remunerative. I mean, you may end up making some money with sales, and that's great. That's an ultimate goal for most people, but just knowing that your work is out there and that people are getting something out of it is reward in and of itself.
Sure. Yeah, no, I think that makes sense. Kind of along the many reasons people go into medicine, if you will, is just to, like you said, more focus on like the impact you can make, or the importance of the story and what it means, what it can mean to people. I think those are really interesting and cool points for sure.
Yeah. Can I add a couple other things to your question?
Yeah, of course.
I don't want to forget a couple other important things. I would say it's important to network, including with other writers, because writers tend to be supportive of each other and to give each other ideas. And that can include getting people to review your work, but also to get ideas of places that you might submit.
Gotcha.
And so that's important. And then these days, it's never a bad idea to start getting a base of supporters or followers with different social media and those sorts of outlets, because ultimately when you have something to launch, that base will already be there to help spread the word.
Sure. Sure. That makes sense. I'm curious, were you someone that did, I know some physicians will do a lot of like speaking engagements or, give invited lectures and things like that. Was that something you had done a lot of? I realize now you're doing that with your book, but before that, was that something you had done a lot of, or not really?
A little bit, because I
Okay.
give lectures to the students and really enjoy that. And then I did give a few lectures with a continuing education company. I actually attended this this continuing education course out of town on a vacation once, and I saw something and I thought, you know what, I think I could do better. And so again, you can't be shy and you can't be bashful. I wrote the guy who ran the course and I said, with all due respect to what you had here, I think I could improve what you had on this if you're ever interested in a different radiology lecture. And eventually he gave me a shot, and then he liked it and had me back another time. And so those are the kind of things that never hurt to just practice what you're trying to do. If you're trying to speak or you're trying to, to get experience delivering this kind of information.
Sure. Something I've had in the back of my mind I want to ask you about is, so you've written, like, and I think we've touched a little bit on this. So you've written a book, which is on its own accomplishment. Where do you go from there to get it published? You obviously you could self-publish it, but say you don't have the time or don't really want to do that, or you want to at least try to see if a publisher would take it. Do you go out, I've heard, do you go about finding a literary agent? Do you more just kind of cold email people? I guess as a physician, is there any way you can kind of, I guess for lack of a better way, leverage your position as a physician to help with that at all, or no?
Yeah, so although the field of publishing has evolved a lot in the amount of time that I've tried dabbling, I can tell you what little I've learned. So the traditional route is to try to get a literary agent who will represent you. They then take your work to publishers and try to get you a publishing contract. Now, that is harder to do than it used to be in a lot of venues, because the publishing industry, there are a lot of reasons for that, but it doesn't, I don't think, make as much as it used to per sale. There are a lot of people who are able to self-publish or publish with small publishers. And so there's a lot more material out there competing for the attention. But so I did go that route, and I went to a physician's writers conference where they actually had agents come and give a brief, they gave like a little seminar, and then you had the opportunity to pitch if you found agents who you thought might be a good match. And I actually there pitched to a couple who said they were interested, and then you send a proposal. So if it's nonfiction, it's a proposal. If it's fiction, you send the entire finished work. If it's a novel, something like that. That's the typical way. I did get an agent, a good one, a New York agent who only did nonfiction. And you do, when you ask, do you use the MD? The answer is yes. You have to have platform which says that you're the voice that needs to present this information. So the more of an expert and the more of an accomplished voice, knowledgeable, informed individual that you are, you're the one who needs to present this. Now, does that make me the best voice for radiology? No, I did the best I could. But anyway, I got the agent, and where that happened was by the time, the revisions were made and this sort of stuff, the publishing industry was changing. And she only dealt with big publishers in New York City. And I'm going to tell you, it took a long time to ultimately get rejected. There were a few who considered it and took their time, but ultimately said no. And so the week that I lost my agent, when she said, okay, I believe in your work, but I think you're going to have to find a small publisher, and that's not really her niche or her expertise. So she wished me well. That week was a little bit of a feeling of dejection, but at the same time that week, I had an opportunity to go to a moth storytelling. Have you ever heard of the Moth? It's a storytelling. It's, if you look it up, themoth.org, it's a wonderful organization of having people come tell live real stories that happen to them. And it happens really all over the world, but certainly in a lot of places in the country. And I had only been twice to the Moth Story Slam events, but I went to one in Washington, D.C. just a couple of days after I lost my agent. And I actually got picked to go on stage to tell a story. And I told one of my book chapters and I won the Story Slam.
Oh, wow.
So it was the shot in the arm that I needed to say, you know what, you've got something here. And just because you didn't find the publisher yet who believes in you, don't give up. And so I eventually found a small publisher.
Great. That's I guess a true story of persistence right there.
Well, once you've put enough work into something where it's hit that critical mass and you just realize I'm going to have to put even more into it, but I've put too much already to just throw it in the trash. You know that this has to see some sort of completion or fruition of some sort. Sure. That's what happened.
Sure. I guess what's the biggest thing you've learned, I guess, from writing this book, like finally putting together? I guess I realize that's a broad question. I think maybe it's a two-part. One, maybe about imaging and kind of the impact it can have, and I guess maybe based on the reception you've seen from these different events you've done and things like that. I've
really enjoyed hearing the feedback from people who read it, especially people I don't know, who have no reason to be kind to me as a friend, but they just simply read it and say, wow, they really got something out of it. I find that very rewarding. And it can be an anonymous Amazon review of someone I don't know, but that makes it all worthwhile to know that people are getting the message that you're trying to convey.
Mm-hmm. No, I imagine that's a very gratifying feeling, especially after all that work.
Well, it is. I mean, but think about it. If you have worked in radiology, whether you're a radiologist or a technologist, if you've ever had the opportunity to show a patient their image, and it used to come up more frequently when we would do fluoro studies, for example, and you're right there, they've swallowed the barium, you've taken the pictures, and now you can say, hey, here is your ulcer, or here is this or that, or this large hernia, or here's where you reflux, this sort of thing. People are always fascinated to see what they're composed of, because it addresses that question that we all carry with us in life, is what we're made of and what we're all about. Because we've got our physical existence and we've got our mental and our spiritual, and you try to piece all that together and what's this all about. And I think people are fascinated to look inside of themselves, literally and metaphorically, and to try to understand what affects what. You need your physical anatomy to be the person you are and to give you the experiences you have in life. And yet we're more than just our bones and muscles and organs. So it's part of that whole exploration. And I think people are always fascinated to look at any human image, but especially their own, and realize, wow, I really do have a spine or a brain or whatever. And I don't think it never gets old to me.
Yeah. It's funny you bring that story up, because I recently did a fluoroscopy rotation, and I remember I had a patient who she knew she had a hiatal hernia, but I was doing the imaging, and like you said, they're right there, they can see it, and she was looking at it and she's like, is that it right there? And then I said, hey, I'll go over the images with you afterwards. And even though she knew it already, it was just so exciting for her to see that, see that pathology and actually see that that's, what it was going on inside of her. And, you see obviously see it real time with the barium and everything. And that was a cool experience, to kind of see what it means to somebody. Like, we do all these studies all the time. And like you said, we can kind of get just caught up in the grind of reading, but it's cool to see how meaningful this is, these are to the patients themselves, not just the medical team taking care of them.
Very much so. And meaningful to the patient and meaningful to the care provider who sent them to us to do the study. And that's what's nice about radiology as well. You're kind of serving two people or two channels here, with the patients and with the doctors or PAs or nurse practitioners whoever is sending you the patients to get this consult of imaging in the first place.
Definitely. So I'm curious, wrapping up here a little bit, what do you plan to write another book, or are you kind of just still I guess kind of working on the promotion side of this one right now?
I I have some ideas. Let's
Okay.
put it that way.
Cool.
As soon as this one was sent to the printer and the editing was done, I will tell you that I've had a whole lot of joy the past year or so reading other people's books and not having to work on anything of my own. I still do a little dabbling, and I can see over time, I think I have some ideas for probably a couple more.
Very cool. Very cool. I guess when you're not doing radiology, when you're not writing books, what else do you do with your free time? What are kind of your passions outside of your work?
Well, because we work in the dark, I love to get outside on my off time. So I like to do a lot of outdoor physical activities like cycling, swimming. I lift a little bit, although you would never know that by the size of my biceps. And different activities. Love to travel, and believe it or not, I like to a couple times a month on a regular basis. I go country dancing.
Oh, cool. Nice.
It's a real social event.
Mhm.
And I think the dance floor, I said in the book, where I believe imaging is the great equalizer,
Mhm.
because you image someone and you don't know who's rich or poor. You don't know their skin color. You don't know their age a lot of times. You don't know what language they speak. All of the things where we may not even actively discriminate, but just the way we sort of categorize people in
Mhm.
different compartments in life. You don't know any of that when you're looking at imaging. And I think in another way, the dance floor is sort of an equalizer, because you don't care if somebody's a CEO or the housekeeper in training. All you know is who's got rhythm and who has a good connection, who moves well.
Yeah, definitely. Yeah, and I think that reminds me, that was an interesting point. I remember reading your book, and I think about that often, that imaging is really in a lot of ways a great equalizer, because like you said, you have no idea what these people do for a living. You have no idea. Even I've been recently rotating on trauma at a level 1 trauma center. Some of these are people that, they were just in the car on the way to the airport, or they were people that were, walking down the street and unfortunately got assaulted, or sometimes there were people that were up to no good and got assaulted. But again, you don't know that. You don't know, even in that scenario, those two, very similar scenarios, you don't know what the cause ones are not. And in many ways, it doesn't even matter, as far as your ability or your role as a radiologist. But I think that's really interesting. And then also the age component as well. Like you said, you don't even know necessarily always that it's an older person or a younger person per se. So
No, I mean, it's pretty easy, depending on the type of study. It's pretty easy to tell the difference between pediatric and geriatric.
Sure.
Even that, that may be easier on a bone image than on a liver ultrasound, for example.
Sure.
And for the vast majority of us who fall in that spectrum somewhere in between, no, there's not a lot of age discrimination on imaging. We all just look like people.
Right. And I thought it was funny. I think you mentioned in there that often you'll forget if it's, a male or a female. And, I've even done that myself. I've seen attendings do it, and, they'll say, oh, where's his, femur or something. And then, there's his femur, and oh, wait, it's a woman now, which is, I think, kind of funny too.
Yeah. I think people who are not in the field may find that a little odd. And of course, we pay attention when it's important. If you're looking for breast or uterine cancer, prostate or testicular cancer, you know what the patient's gender is. But if you're looking at a heart or a brain or an extremity, again, we all just look like people.
So kind of wrapping things up here, Cullen, I wanted to ask you about, kind of reflecting on, writing this book, and then even more so your now long career in radiology. I guess, when you reflect back on what comes to you, after kind of exploring this aspect of radiology, and even just your own, just your career in medicine in general, maybe any kind of parting advice you would have for the listeners out there?
That's a good question. I've very much enjoyed the career that I've had, which I'm probably roughly 2/3 through. And the main thing that I would say is it's amazing how it has evolved over time. And so what I would say, if any of your listeners want a little bit of unsolicited or perhaps solicited advice, is one, just be prepared and expect a little change over time. And with that, I think it's important to maintain your skills, maintain a breadth of skills. I know that a lot of practices, not only academic, but even private practice, are getting quite subspecialized. And mine is certainly a subspecialized practice. But I think there is a little bit of a risk both to the practice and to the individual radiologist if that goes too far. Because I still think we've had the training that we've had, and one should maintain their skills to some degree. And I can give you a few examples. I've seen people who, for example, were very good at nuclear medicine, but did not maintain CT skills. So the nuclear medicine skills were fine until PET became more prevalent. And then all of a sudden they were running into some issues. People who do only breast imaging, I know that's becoming the norm now, but to not be able to read a chest x-ray or a pelvic ultrasound because you only do one type of thing, I think is a little bit extreme, because modalities change and people change jobs. You may take a different job someday where you're expected to do things that you haven't done in a while, or your own practice may have to shift work assignments around in order to cover and balance, and you may need to start doing something you haven't done for a while. So don't give up too much, I think is one bit of advice I would leave people with. And just remember that modalities change too, right? I mean, it was in the mid to late 1990s when I was a resident when CT angiogram became common for pulmonary embolism detection. And of course, now it's the gold standard and it's the norm, but it was new back then. And the gold standard, pulmonary angiography, is basically obsolete. And that's just one example. So the imaging evolves, and so we need to keep our skills up. It's not always easy, but it's something we have to do. The other things I would advise people are to get involved and make yourself useful in other ways besides reading images. And there's so many ways that you can do that, whether it's academic or private practice. Somebody needs to pitch in terms of things like protocols, or get involved with billing and coding or marketing and physician outreach. There are all kinds of ways that you can get involved, scheduling, these sorts of things. Some of them are more appreciated or thanked than others, but they're all important. So find whatever is of interest to you and do that so that you're contributing in another way.
Yeah, definitely. It's, even in my own residency, I see where there's a lot more to the practice of medicine than just the actual medicine. There's, as you said, there's, marketing the practice or marketing what you're doing. And then, quality improvement, those types of things are all definitely help make things better and make better patient care. And then also, like you said, are appreciated, hopefully in most cases.
They are. I mean, people may not always say thank you, but they're appreciated because they're necessary components of how a department needs to run.
Definitely. Yeah. And I think, it seems like there's a lot of people who, you learn a lot of these procedural skills and things like that. And you come out of residency, maybe the most versatile you'll ever be. And I think, trying to maintain that is, to stay versatile, is always the best position to be in. I've heard of, like interventionalists that, they did IR for 10 years and then they joined another practice, and that practice wanted them to read diagnostic, and they hadn't really read a scan that wasn't an interventional case in, 10 years. And so I kind of put them in a tough spot. So yeah, I think I've definitely heard other examples out there to echo exactly what you're saying, for sure.
Yeah. I mean, you have to be realistic. It's not easy to maintain high-end neuroimaging and high-end breast imaging and vascular interventional work. I mean, you do have to focus on what you do most commonly and what you're best at. But again, I think there's a danger in getting hyper specialized where your work may not always allow that to happen, because again, people can take different jobs and the technology can change within a practice regardless.
Sure. Okay. The other thing I want to do before we wrap up here is let people know where they can buy your book. And I have it right here again, Looking Within. Where are some places they can go find that?
Well, bless you. I really appreciate the pitch you're giving there. It's available wherever books are sold. So the standard digital formats, including Kindle and Apple Books, Barnes & Noble, Nook, and then of course physical copies can be at any bookstore as well as the online, Amazon, etc. And I've got a website. If people want signed copies, so that's my name, www.cullenruff.com. And so really wherever books can be sold, it can be ordered.
Great. And I think you said it had been placed, I think in the imaging category on Amazon. It was a bestseller. It's been a bestseller there for a number of times. Is that, you were telling me that before we started recording?
It has. It's books are a competitive thing, and so the rankings always change. But I've been very lucky because of getting some good reviews, and so good reviews allowed Amazon to promote it a couple times. And the digital Kindle version, certainly, I'm grateful to say, was in their niche. There are several hundred niche categories within Amazon Books, from everything from, you name it, they've got all kinds of categories. So to say that a bestseller in biography or mystery is going to have a few more sales than human imaging or breast cancer, which was the other category, that it was at one point considered a bestseller. And so I'm just grateful for whatever I've been able to do with it. And if somebody wants to read it.
Regardless of what category, I think that's quite an accomplishment. So that's great. And then the other thing is, where can people follow you on? Are there any social media platforms? You mentioned your website where people can follow you on there. Any other platforms where you're active on?
Sure. I'm not the most active, but yes, I'm on there. I'm on Twitter at Cullen Ruff. I am on LinkedIn and the typical professional sites there.
Okay, great. Well, we will put your website. We'll put the Amazon links and your other links in the show notes below. And again, it was a lot of fun talking with you. I certainly learned a lot about my career or my field of radiology and what to look forward to in my career ahead. And I hope the listeners did too. And thanks for sharing your wisdoms, both on radiology and then also with composing and publishing a book.
Well, it was my pleasure to be on here. I just wish everyone, whether they're students, residents, or early in practice, I wish them the best in their careers. I've had a great one so far, and I'm very happy to still be doing it and going strong. I think we've got a great field, and we can do a lot of good for a lot of people.
Absolutely. I 100% agree. Well, thank you again, Cullen. We appreciate it.
Best of luck to you, and thanks again.
Thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. More episodes are available on our website at dviacademy.com, our YouTube channel. They're also available on Spotify and Apple Podcasts. Also on our website, you can find our video courses for anatomy, biochemistry, and histology, and they're available as month-to-month packages. They're also available as a combo package where you can get all 3 courses in one. Our website also has a store where you can find our outline format textbooks for anatomy, biochemistry, and histology. All textbooks are available in paperback version and as eBooks as well. These textbooks complement our video courses and provide a nice addition to the learning experience of allowing you to focus on the learning and not having to write anything down. On our website, we also provide a free clinical cases video series called DaVinci Cases. DaVinci Cases aims to help you learn how to answer USMLE questions and apply concepts that you learn in our courses to answering those questions. Our cases cover a variety of topics and organ systems, and they're updated frequently with new cases. And then lastly, on our website, you can find our blog, which has interesting articles that cover medical history, important figures in medicine, and innovations in medicine. Again, thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. Please be sure to tune in for our next episode.